Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
And then you were asked something on ERAS. This is what I like to call it, the enhanced recovery after surgery. Now, when I talk about ERAS, and you know the full form, you're very happy that it's enhanced recovery after surgery. But then what? Remember that this important thing of enhanced recovery after surgery is not exactly steps that you are doing after surgery. It starts right from the time the patient was admitted into your hospital. Basically, this entire thing was to improvise the experience of a patient undergoing surgery. How many of you have been through a surgery in your life, yourself as a patient? It is the most dreaded experience in at least it was in my life. I know, or we know too much about our field, and we know every step, we know everything, when the anesthesia is going to be, when the spinal is going to be given, how it's going to prick, where is it going to go, what if this happens, what if that happens, and the complications are more in our mind, clouding our mind with the complications rather than the good prognosis or the good of our case. No. So this is actually, again, a European, what do I say, concept. We Indians are too busy in just treating the patients rather than thinking about the good experience in surgery. So it's a European concept of improvising the entire experience of the surgery of a patient. How a patient can see this particular event in their life as a pleasant experience. So when you look back, the good memories are, maybe a picnic or an outing or some function, a family function or a vacation in your life. They are pleasant experiences. Idea was to make this particular point in her life, his life, a relaxing experience. Okay, you obviously cannot take out the anxiety associated with it, but you can make it much, much better than what it is in our usual hospital setups. They have problems right from admission, then they have problems to stand in the line for getting their test done, then they have to take the test reports, then they have to show it to the doctors, wait for the doctors, then end up showing them the report, taking the timing of the surgery, getting admitted on the day of surgery, right from staff management to pre-op anxiety, the drugs being given, the cannula being placed, the shaving, the preparing, the shower, the antibiotics, the sensitivity testing, everything is, an experience in itself. And I'm telling you, none of them is a very pleasant experience. So this entire schedule of enhanced recovery was designed taking into mind the important thing the patient undergoes and what all experience can be improvised. Okay, so again, I'm telling you, if you write down in your exam only after surgery what all things happened which made a person recover better, you will lose half the points in the question. Because as an examiner, I know this is where the students are going to fumble. They are going to write down everything up after the surgery because the name suggests so. Well, actually, it is not true. It starts right from the time the patient has come to see us till the time she's finally discharged from the hospital. Usually after the surgery, for most of the patients, it's a pleasant experience anyways. The maximum tension is gone. Post-op pain is being taken care of by, the post-op medications. Doctors coming to see you every day. Nurses are checking up on you. You're feeling relaxed. And finally, now you're counting days to go back home, right? So it's a pleasant experience. It's the the night before the surgery, the days before the surgery, they are most toxic for most of the people. This is where we hit with the ERAS, that is enhanced recovery after surgery. And this, of course, is huge. I have given you this entire concept, but how to write down, you should have some points, which is why I've included these slides. You go through the slides. Obviously, the PPT will be uploaded as well with in my live class recording folder. And you go through the PPT as well, so that you're able to have now something to write down in this answer as well. So we want fast track recovery, rapid recovery, accelerated recovery with a pleasant experience to optimize the patient care, resulting in the reduction in the stress response to surgery. And now it is a standard practice, okay, in Western world. It still is not so much in India. This, if you know, this particular, chart, if you know, it has everything in it, and you do not need anything further than this chart to write down an answer on ERAS. If you just make this chart for me for a 5-mark short note, I will give you 5 on 5. No point should be missed. So it starts from referral from the primary care. Okay, so you came from somewhere and you met the doctor and now you're admitted. So there is pre-op going on. Pre-op preparation, sorry. And you've just met the doctor and pre-op investigations are on. Finally, you'll get admitted. Then obviously you're going to get your operation done. And then this is post-op and then the follow-up as well. So what all things are important in this? So first of all, you need to have an optimized pre-op hemoglobin levels. Okay. You have to manage the comorbidities, for example, diabetes, hypertension, hypothyroidism, so many things before you are finally admitted. Optimize the health, medical condition, informed decision making. Obviously, you are being admitted for something. You will not get admitted till you know what you're signing in for, right? I have told you to get a hysterectomy done, but I also given an option for myomectomy. I also given an option of UAE or MRGF-US. I gave you an option for medical treatment as well. Now you are getting admitted for myomectomy, knowing all these pros and cons. So for me, very important is informed decision making. And obviously, I'll give you this. What do I say? Options on the basis of your health. So pre-op health risk assessment, entire patient information. The expectation is managed. Everything, discharge, planned date agreed with the patient. So patients over there, they have a lot of questions to ask and you have to answer all the questions very, very patiently. Unlike in India, it's a very, very different scenario, what it is outside and what is inside in India. But in India, you have to also know that this is the standard of care being recommended outside. So someday it's going to come to India as well. The culture is changing very fast. I have all throughout my life worked in corporate hospitals. So for me to understand these things is pretty easy because I've been with these kind of patients, okay, who have a lot of questions to ask, will not be satisfied with you if you're trying to, shoo them away. It is that we'll take care of. You don't have to think about it. They will not be happy. They'll choose another doctor. Okay, and your doctors will make you understand that how important it is to convince the patient. When a patient is asking, if you're not able to convince them, send them to us, but you're not doing a good job learning these things. Because when you will go and we will sit in the market, you will see that such patients come to you more often than the other class. This is changing. The culture is changing slowly, but definitely steadily, and you need to master all these things. On the day of admission, it was seen that admitting the patient the same day of the surgery improved the scores. Okay, it was seen that if you optimize the fluid hydration, the IV fluid hydration, it is a better recovery later on. Carbohydrate loading before the surgery is enhanced recovery later on. We do not starve the patient. If you starve the patient, you see that she doesn't recover very well post-op. So these are very important points. This is the points which the examiner is going to see when they want to see what you write in ERAS. Okay, so you have to write down these points. You do not have to starve the patient. Carbohydrate loading, IV hydration, admission on the same day, reduce bowel preparation, because it's very disgusting for the patient and doesn't help post-op as well. According to these researches and studies, I still disagree. Minimal invasive, intra-op minimal invasive surgery is far better. Transverse incision, the length should be adjusted. It should be limited. Okay. Transverse incision far better than the longitudinal incision. No nasogastric tube, not very good for post-op. Regional blocks better than GAs. Epidural management better than regional block. I'm sorry, but better than spinal. Optimizing the fluid management even during the surgery. Individual goal-directed fluid therapy, very, very important. So in intra-op, you have these things to take care of. Again, very important. Very serious things are going on. Okay. Admission, very important. Pre-op, what do you want to do? Very important points. Intra-op, very important points. Post-op, again, very important points. Planned mobilization, very, very, very important point. Okay, guys. We do not stress so much on this, but VTE, venous thromboembolism, is directly linked with how quickly does she stand on her feet. Literally. So planned mobilization, rapid hydration, nourishment, appropriate IV therapy, no wound drains, okay, no nasogastric tubes, catheter to be removed early, regular oral analgesia. Yes, paracetamol NSAIDs, give them, because unless you give them the paracetamol and NSAIDs, they will not stand up and walk. Okay, they'll keep complaining of pain, let me lie down. Give them NSAIDs and make them walk. Remove their catheters, let them go to the bathroom themselves. Do not put them under any nasogastric. These are all studies have taken place on all these points, guys, and these have been included in ERAS because of this entire article. This entire study has been brought to you because these things were done and they found a direct association Movement of or recovery after surgery with these points. As the name suggests, enhanced recovery after surgery. These things they did, and they found that the recovery is better. People were going before at 7th day post-op home. Now they're going on 4th day post-op home. There'll be a day when they'll go on the next day home. Okay, you do everything at home. Take the antibiotics, also IV antibiotics home, and there'll be pumps and everything coming. So you never know how it's going to be, but yes, things are improving for the better. Nobody wants to stay in the hospital for a longer time, and we give them that advantage. We basically want the well-being of the patient. That's all. Then NSAIDs, avoidance of systemic opiate-based analgesia. And as far as the discharge is concerned, you support them. You give them your number. You let them know that I'm there for you. You can give them a 24-hour helpline so that whatever problem is there, we are there to help you. Okay. Basically, this is what are the points of enhanced recovery after surgery. These are the things that you have to see to enhance the recovery of the patient after the surgery, which starts just see it's starting right from here, right from optimizing the pre-op condition of the patient. Because until and unless I've seen cases where patient was she never knew her sugar level. She came in the morning. We said, fine, let's just check her fasting sugar, and fasting sugar was fine. We didn't go in for checking HbA1c. That was 8 point something. Okay, we got to see that she's not improving. She's having wound infection and everything. And out of so many tests we sent with HbA1c, it came out to be 8.5. She took a very long road to recovery. Very long road. Why? Because the right time comorbidities were not checked. This thing of just a random blood sugar or a fasting sample alone is not sufficient sometimes. Okay, you have to take these things very seriously pre-op. Okay, a very long road to recovery. So it starts right at the time of, so please, this is what I'm trying to insist in this lecture, that if a question comes on ERAS, please be sure that you start from pre-op, right from the referral of the primary care. And all these slides, guys, that I've included, this is only to give you some material to write down about. Okay, so the same thing is being said over in these slides. Peri-op care, what all do you have to do? See mechanical bowel preparation. We do not do it much. If you do not do it, they've seen better results. Okay, dehydration to be avoided. Same thing which I've just spoken with you. Post-op, you have to mobilize them fast. Very important. See, you give them enough analgesia, let them move. Let them move. Discharge the patient criteria based when you can, and nurse-led, units. If she's there for you, you can call her, you can talk to her. And of course, the very important thing is involve the patient and their carers at every step of the process, right from decision making to the discharge. Very important, fundamental step. And empowering the patients to take significant roles, and you should not have a passive sick role. You should have a very active role in your decision making. It's your life. In India, what happens? The sick patient is sick. Sometimes she's not even there inside the chamber when we're discussing that she should go for a hysterectomy. She doesn't know. She's not participating. We're talking to their carers. Most of the time it happens this way. Oh, she's too scared, ma'am. Let's let her be out of it. I never do that. Yeah, to maybe to respect the demands of the carers, I do that. But then eventually I call them inside. You speak to her, let the news be known to her, but I'm not letting her go from my OPD till she has spoken to me regarding what's her opinion on this mode of management. Maybe this is not what she wants, right? Okay, so with this, we come to the end of tonight's lecture, guys. These were two very important things that I wanted to tell you about, and I wanted to show you how you're supposed to maybe answer even if you're not knowing the question very well. So these two things I wanted to let you know, and this lecture is going to be up on the channel very soon. And if you've got any questions, anything to ask me, let me know. Yeah, you people have asked me for a couple of topics, amongst which I like this suture thing very well. Suture, needles, and I think knots, right? So immediately after, right now in this lecture, let me know what all knots. See, there are so many knots that I know. Okay, reef knot, reverse reef knot, surgical knot, so many things. But what is important from a gynae point of view, those knots I'm going to teach you. But if you still want to learn more knots, you can write it down over here. Let me know. which all knots exactly do you want to take up, as a tutorial on, and I'll include that because I don't want to take half a lecture in which half the things which you wanted are not covered. So yeah, sutures I'm going to be needles. I'm going to be teaching you what is taper cut, reverse cut, round bodied, semicircle, how 3/8 circle and 1/2 circle and all that stuff. Then I'm going to be teaching you what is the importance of that. And obviously, as a surgeon, you should know all these things because when certain the nurses, they ask you that what kind of suture you want, you shouldn't fumble at that time. When you want 2-0, when you want 3-0, when you want vicryl, when you want PDS, when you want silk, that things you should know. So I think, guys, you're gonna just give me a message. That will be sufficient for me. I have no problem. And with this, I finish the class tonight. Thank you as always for being such interactive and intelligent audience, I must say. All my students over here right now in the class. I'm going to be coming up with obstetric classes real soon. I'm going to have a real blast. We're going to take up very important topics and going to do them step by step like we did in gynae. And this time I'm going to be a little more, structured. Mostly the lectures when I started them off, I just started them as a way of interacting with you. But then I saw the response. I saw people are interested. People are taking an effort to see my lectures despite them being on their duties or off duties, on vacations or wherever they are. They're trying to watch it or making an effort to watch it. I got more encouraged into giving you lectures which are of importance to you. So thank you for being such excellent audience. And I say it again and again. In all humility, all this is coming because of you are the force that is driving me. You are the motivation. So keep giving me these inputs as to what you want a class on, what things you couldn't understand better, what things do you want more. Be more verbal. I'm always very, very inviting. Do not be scared to reach up to me. My WhatsApp number is always there. All right. And just anytime you WhatsApp me, I always respond back. So do not worry about it at all. Okay. So with this, I finish the class tonight. Thank you so much. Yeah, same here. It was very nice meeting you all. Actually, currently also right now, I'm so busy with my fellowship, but I just couldn't sustain it. I had to meet my students, and I did not want this, this flow that has become for my classes to go anywhere. So I'll try maybe to take one more lecture, and then we'll meet in January, obviously, as the new year is coming. Let's see if I can squeeze in one more lecture on this, and keep writing to me. What all do you feel should be taken up? Thank you. Thank you so much, everybody. I conclude the class for tonight. Thank you, everyone.